All right, Dr. Quesada, if you'd like to introduce yourself and go ahead and get started.
Oh, thank you. For me, it's a pleasure to be with you today. Thanks for the invitation. Good morning, everyone. When we think about thoracic trauma, we usually imagine a complete emergency room, probably trauma surgeons, ventilators. But today I want to take you to a very different environment, deep in the jungle, in the Ecuadorian Amazon, where the first critical decisions are made uh, actually out of the hospital and not for physician. No? In this case, um, we have some decisions who was taken for the EMTs and firefighters department paramedics. I'm an emergency physician. I am actually in the Morona Fire Department, like a medical director, and I'm a volunteer in my town in the fire department too, and have a designation of a leader of medical unit of USAR team. So all the time I have a rescue team's work, and today I am going to present you probably the best case in the last year. Um, I I ask to think you are in the jungle. That's our ambulance. Is located in Macas. Macas is located in the Amazon, in Ecuadorian Amazon, very close to limit with Peru. So we don't have the same resources who we have in the big cities. So it's a small town with a lot of communities, about probably 1 or 2 hours or from the Maca Center. Okay, then our case today is male, 30 years old, driver of motorcycle. In these towns, don't used to use a helmet. No, all the times you have a lot of victims of this motorcycle accident, and he was a very high energy victim because he crashed with a bus. So the ambulance of the firefighters department have to travel. You can see in the image about 1 hour and 41 minutes. That's the Google Maps uh, say, but in the reality, it's probably about 2 hours of travel to come to start with the care of this patient. So in these areas, we have a little health centers with probably a nurse and a rural physician who was the first care with this patient. So they initial the evaluation and called for help with the ambulance of fire department. When the ambulance arrives, start with the primary evaluation and next no life-threatening bleeding. So then continue with the and start a manual airway opening and cervical immobilization. Here you can watch the real picture. You can watch Christian. Christian is I think the best paramedic in my country. He starts with manual airway opening and start with decisions. No, you can imagine what happened again because you can watch the mental status in the first evaluation, rapid evaluation. You is lethargic, is not a conscious people. So start with the manual airway opening. In the B, the paramedics can find subcutaneous emphysema and absence of breath sounds in the right side. Tachypnea, hypoperfusion signs. So they have to decide rapidly to have a needle decompression and then connect with a hemorrhage valve in the fifth space in the right side. So with that, they can stabilize the hemodynamics findings because they were thinking in an obstructive shock, probably tension pneumothorax. So then continue with evaluation when in the Glasgow score, they have 8, so they have to take the deal decision. So I want to take, or I want to ask to the audience, because here is the first probably difference of decisions, no? Intubate or not intubate, because it's easy at the beginning, ventilate with the BBM, so have a needle decompression with a needle. Now is the patient stable, but we have to think in about 2 hours travel with the in the ambulance with this critical patient. I don't know if you or something can answer this question. Probably, what do you think?
Okay, why we don't go around? Dr. Untra, will you intubate or not intubate?
Yes, well, so the patient was tachypnic, very bad sign. And remind me, his pulse and blood pressure, do you know that?
Actually, blood pressure in the first evaluation rapid, he don't take the exactly blood pressure, but the nurse was taking was 115/18.
And the pulse?
Pulse was present in the
Not tachycardic, not tachycardic.
not tachycardia.
Okay, very, very good. So, well, you know, it's a Glasgow Coma scale lower than 9. It's 8, but still lower than 9. And in this case, especially the long travel distance, I assume no helicopter. And as long as he's got adequate circulation and he's been stabilized with the interthoracic catheter and the Heimlich valve, so I assume that he's now breathing with assistance, but I assume that you got a rush of air, so corrected the pneumothorax and it's not pouring out blood. In that case, you know, if the EMT can safely intubate while maintaining immobility of the neck, then he can do that. So it's very important to maintain immobility of the neck. If he can't intubate without moving the neck, but he can maintain an airway non-definitively, I would do that. So it's a really, really close, it's a close judgment call. But if he can do it safely without removing, without immobilizing the neck, then I would go ahead, because he's unlikely to be made hypotensive by the medications needed to help intubate.
So, Dr. Frisbee, what will you do?
When you put your needle in there and you established that he's got a Heimlich valve now, what happened to the SAT?
It's better. Up from 84 to 90.
Okay. Well, I agree with Dr. Umtrek. I think if you can do it safely without disturbing the alignment, then you need to intubate this guy. He's got a 2-hour drive, right?
Yeah, about 2 hours in
probably not a bad idea.
Wait.
If you can do it safely, I would do that.
Okay, Dr. Kasim, will you intubate?
Yes, the answer is yes.
Yeah. Okay.
And the reason being, you don't know what's going to happen in the 2-hour travel. You know, many things can happen to this patient. And on top of that, you know, he has significant hemodynamic instability to begin with. Now he's somewhat stable, but all hell might break loose when you are about 10-15 minutes in the ambulance. And then what are you going to do? I think for those reasons, and also ATLS teaches us, Glasgow coma scale 8, they recommend that we intubate the patient. And I agree that you need to be aware of the patient's neck. He may have undiagnosed cervical injuries, but you know, you do the very best you can to provide safe journey to the hospital, so that he can have a good airway and arrive there safely? The answer is yes.
Okay, Dr. Collet, will you be the one saying no?
I think there is a problem today. Intubation in pre-hospital require is sometimes not be, we can control the patient with no invasive airways. It's possible because if you put intubation, the patient may be hemodynamically unstable and maybe decrease the problem. You can see in I saw because of the discussions I was have in Israel last week that I was there, the evacuations of the trauma area on the Gaza was usually be not intubation, usually maybe use no invasive airways and blood transfusion and avoid any other procedures, inclusive chest tube in this emergency in this area. And the result is very, 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 very different that we are seeing today. So I think the intubation in this case may be wait, and then you can transfer. If the patients have some signs of instability, you can try to maybe other intubation. But this patients is very sometimes important. The patients can be safe in go without airways, invasive airways. Can use no invasive airways maneuvers to transfer this patient. Avoid intubation and hemodynamical alterations during the intubation. I think these patients can be stable, may I see here, and then can be transferred with initially with no invasive airways.
Okay, so one for no, and Dr. Epstein.
I'm on the side of intubation for several reasons. One, if you're going to bag somebody for 2 hours, you're going to fill up their stomach, and there's a good chance of aspiration along the way if you have a good seal. And second, ATLS, as Dr. Kassim mentioned, ATLS says intubate for 8. The criteria are right there. And the question is, what would you use to intubate? And do you have some of the more modern instruments to intubate rather than just the old style Mack or Miller tubes?
Dr. Collet, would you like to respond?
I agree that you can intubation will make more safety, but sometimes intubation may be not important in these situations. If the patients can maintain airways with no invasive instruments, may be safe for the patient. But I agree that the problem of the aspirations is a problem principal because the transfer in this runway may be unstable and some problems. There's not a good airway transfer. They can be quickly transference.
If you disturb that, but you can comment whenever.
Okay, okay.
Time you want, anytime. I'll be.
Tada, if you want to continue with the
So, in that moment, I received a call from the EMTs. I was in my hospital in Cuenca. For lucky, I was this day in the emergency room with Dr. Salamea, no? So I have a little of help, but all the time I have to decide for that because the paramedic said me about his evaluation. He said a Glasgow score 8 placed the patient in the severe head injury category. So at this point, we consider him at high risk of a lost airway reflex and aspiration. So probably in a hospital setting, this will clearly be an indication of the early airway, probably invasive. But in this moment, we have to decide. And we talk and decide and think in the probability of when they start with a positive pressure, when after the intubation and start with the mechanical ventilation, probably this pneumothorax can be worse. So I asked if the evaluation of the thorax could be a possibility of complicate with a tension pneumothorax through the travel. So we have to decide, and probably the I don't know, the worst complication, the big problem in the pre-hospital care is do it safely. So we have to decide, sedate the patient. In answer of one of the panelists, we have in the ambulance supraglottics like IGEL, and we have video laryngoscope too. So we have all the necessary to do with the adequate technology. So probably the big problem for the EMTs was how to sedate safely, because we don't have an anesthetist, or we don't have an specialist in the field. No, just I am in a call with my team. I don't know, in this new question, we decide to do the intubate, but how to sedate safely in the pre-hospital settings. I don't know what's your analysis.
So, assuming that you intubate the patient, you have a 2-hour trip, you probably have to give some sedation. And I don't know what type of sedative you have, but if you have a choice, what would you do? Dr. Epstein, why we don't start with you? Oh, I'm seeing a comment that Dr. Fraga wanted to comment. I'm sorry, Dr. Fraga. Can we give the
Go ahead.
microphone to Dr. Fraga?
Oh, sorry. No, so my opinion about the intubation, I think there are 2 hours for transfer the patients. Very, very important to pay this patient. And if you have a physician at the scene, I think I put a chest tube on the right in the pneumothorax. I think to transfer this patient is very important. And about the drugs for intubation, depending on what you have in your ambulance. You have different kinds of drugs. If you have fentanyl, etomidate, depending on what you have, but sure you need to sedate these patients. Thank you.
Okay, Dr. Einstein, I'm sorry I interrupted you.
No problem. I guess we should know what they have before we make a comment of what they should do. If you don't want the patient bucking, there's still a chance of aspiration. Did you put an NG tube in or an OG tube? So perhaps the doctor can tell us what the ambulance has, and then we can go from there. But etomidate is not a bad drug to intubate if you're in the field.
So I'm sorry, we don't have etomidate in Ecuador, so.
Okay, what would be next? Then what do you have in the ambulance?
Okay, in our ambulance we have fentanyl, we have ketamine, rocuronium, and midazolam. That's our options.
Okay, so there are many options. The question there is if you want to use a little bit of fentanyl and a little bit of ketamine, because if you use rocuronium and you can't intubate, you're then stuck for a while bagging the patient. If we've all agreed, except one of us, that you should have the patient intubated, I would go with a little bit of fentanyl and a little bit of ketamine. The dosages would vary according to what your protocols are. But I don't think, unless you have a very skilled person, I would use rocuronium.
Okay, Dr. Kasim?
I totally agree with Dr. Epstein. That's exactly what I would do.
Okay, Dr. Untrach? You're mute, Dr. Untrach.
Yes, ketamine is a very good drug, and so I would be in favor of that, and it doesn't cause myocardial suppression, so is less likelihood of hypotension. The other thing is, if you really needed to get an airway and this were difficult, the patient were thin, in certain cases, I think that, you know, if you couldn't position the head, whatever, I would, for a long trip, I would strongly consider a cricothyroidotomy if there was, you know, if you're worried about losing the airway and having control. I think that's perfectly okay, and you can do that with a little xylocaine and, you know, and even a size 7 endotracheal tube, and then you're on your way. And so I would keep that as the final option.
Dr. Frisbee?
Well, I agree with all those comments. I think that if you rocuronium comment was spot on. I mean, unless you're really good at this and know what you're doing, that might be iffy. But the other treatments certainly.
We don't have to. We don't have to.
I think I would save the crike for the very last thing I would try to do.
Everybody's in agreement. This is too boring. Dr. Collet, will you help me find something different here?
I think the great problem is it can become a very big problem because you don't have adequate equipment for intubation in this area, and it can be more problems with this intubation. So I can use ketamine and rocuronium, but if the pre-hospital don't have experience in intubation, the patient can die because this, or can be ventilation and it have more risk of aspiration, because when you make ventilation to the patient, you can insuffle the stomach, and then aspirations may be more easy to occur. So I think in these patients, you have a safety airways. It was respiration. The volume of inspirations is normal. Maybe you can wait, but if you don't have chance, you have to think that you more safety is intubation. You can use in this situation ketamine, and then you don't have succinylcholine, you can use ketamine. So you can maybe try to make intubation. If you don't finish the intubations, you can go and make a cricothyroidostomia, but not make cricothyroidostomia if you don't try the intubation. I think is not good.
So let me play devil's advocate here for the group. What about if the sedation cause hypotension in a patient with head injury? Because if you intubate, you have to sedate, and now you risk hypotension in a patient with head injury. So that will support, and you have a long transport time. So is that a concern for anyone?
That would be a concern if I'm using ketamine, but it would not be a concern if I use anything else. But then you can adjust the dose and hope for the best.
Okay. And what about an OG tube in a patient that we don't know he has facial fractures or basal skull fractures? This is a motorcyclist that was not wearing a helmet. And it seems, based on the picture, they had some facial trauma. Is any concerns about trying to decompress the stomach that way? Or if they have decreased mental status and put in the tube, he might vomit. So
once you get the airway secure, then you can move on to protecting his esophagus, stomach, and the problem of aspiration. And that's the way that I would go.
okay.
Might I ask the level of paramedics that are at the scene and EMTs?
Okay, so in our guide, we have right now continue with the discussion, not in the medicines, just in the dose. No, we have established use fentanyl, ketamine, and rocuronium. No? We adapt this United Kingdom protocol. They in this paper compare the traditional protocol 3-2-1, 3 micrograms of fentanyl, 2 of ketamine, and 1 of rocuronium versus 2-1-1, no, 1 to 2, 1 microgram of fentanyl, 2 of ketamine, and 2 of rocuronium. No? And they don't found a significant change in hypotension, so that's a good news. But in the first pass usage in intubation, all this in the pre-hospital care, he was a difference. No, with traditional protocol, he have an exit first pass usage of 86%, and with the new protocol, when you have a higher rocuronium dose, they have a 95% of first pass success. So now we are in the adaptation of this to our service. So in this case, the paramedic decide to use the traditional protocol, and he have an first pass exit with exit node using fentanyl, ketamine, and rocuronium in the traditional dose 3-1, and in the first pass he can intubate the patient without complication. And this was not just an airway decision; it was a time decision too, because we have a long travel to the hospital and prolonged transport to the difficulty in the terrain. So with no access in the way to additional resource, so we have to think in the probability of have less resource in the ambulance, because here he was in the health center with more people, with nurses, and we decided to intubate, and we did it with exit. And then we continue with the evaluation, with the primary evaluation, and he's exposed and shelters the patient, and we in the complete physical exam we have this news now. So probably the best or the more critical lesions were in the thorax. We are thinking after the intubation, the tension pneumothorax, because the patient after that start with hemodynamics instability. So reevaluate, and they found an absence of zones in the right side again, expansive thoracic subcutaneous emphysema, and severe extremely distress. And the paramedic who was in the BBM said the difficult now is a resistance in the ventilation. So we have to think in the new travel. That's an example of the.
Acá hay que llegar, y acá estamos.
You can see it's not a good way, so we have to drive very slow with the for the care of the patient. So probably we have more than 2 hours of the prolonged travel. So you think in this, or we have to think in this time, who is needle thoracostomy enough for safe transport of a ventilated patient, of probably you suspect of attention pneumothorax risk in the middle.
Okay, well, we're going to start with Dr. Colena, who was the one saying not to intubate for this particular reason.
Yes, that's the reason. And I think the great problem is to put this patient to have an injury of the lung, but they was ventilated adequately without intubation. When you put an intubation, we can increase the risk of tension pneumothorax. So in this situation, may put a chest tube in this patient to drainage the pneumothorax. This is of course. So it's a great problem. If you don't do this, you can transfer the patients only ventilation, support of oxygen, and then you can transport the patient without the risk of pneumothorax or hemodynamic instability. But if you have a pneumothorax in the initial assessment, you make intubation, you can put a chest tube.
Right.
Okay, intubation, if you decide to intubate, you put a chest tube. Okay, Dr. Frisbee.
Yeah, that's right.
Okay.
If you've got him intubated, there's no harm vis-a-vis his pulmonary status or putting a chest tube. And I think it's a lot safer for 2 hours of riding around in the jungle. And I understand why you have to go so slow. I mean, you don't want to give this patient a rough ride. So if you've got him intubated, it's probably safer just to go ahead and put that right chest tube in. That's all I got.
Dr. Kasim?
A couple of things I want to stress in the process of putting a needle thoracostomy here. Dr. Trunke, who's passed away, used to teach us that you take your palm of your hand, left hand, and you put it in the axilla, and the middle of the palm is the area where you put the needle. And it is the same area where you put a chest tube as well in an emergency situation. And I would definitely recommend that for others to ponder about that a little bit. And I agree with Dr. Frisbee that once you have the airway secure, there is no problem whatsoever if you have the equipment available to put in a chest tube. And if you don't have the equipment available, there are other modalities of modern equipment available nowadays that you can insert into the chest cavity from further assault from tension pneumothorax. And these are the things that you should be aware of and perhaps carry some in the ambulance. There's a friend of mine who was in a situation like this, and he used a 5mm trocar that we use for laparoscopy. He made a small little nick and inserted the guide wire and then followed it with a 5mm trocar and inserted this chest tube, which is another novel way of treating this. Thank you.
So if I may refocus this, and Dr. Quesada, please correct me. I think the discussion here, and I think Dr. Colette pointed this out before, you're in an austere environment with paramedics, not physicians.
No,
They might have limited resources in the things that they can do. So we might be able to put a chest tube, but what about the paramedics? Can they put a chest tube?
that's true. That's the decision. No? We are in middle of the jungle, just with paramedics. Actually, have a one physician, but is a rural physician. So recently graduate physician who were very scary. So that's the problem. No, it's not a surgeon or something with a competence. No, the paramedics asked me for the permission to do invasive procedures or use medicine. So I'm the medical director. So probably you can think in that too, because if you have to take the decision like a medical director, you approve the chest tube for the EMTs or the paramedics.
But are the paramedics allowed to put a chest tube or not?
Actually, he have an experience in CPR and traumatic CPR. He did not a chest tube, but finger thoracostomy, simple thoracostomy, just
Okay.
in cardiopulmonary reanimation, no? Not in the similar situation, but they know about the technique.
So was a tube thoracostomy, a finger thoracostomy, an option for this patient? Dr. Quesada, your paramedics can do a finger thoracostomy. Okay.
It's an option. We have the kit.
Finger thoracoscopy. Okay, so Dr. Untrach, would you recommend that in this case?
Yes, that's what I was waiting to say, because it's, I think in the jungle, in limited resources, and I'm sure you're doing this, but all the people that are posted there have to be the best, especially working in remote locations. Because if you have somebody that's not, not the best of the bunch, you keep them in the big city. Don't send them out by themselves where there's no backup. So, and then they should be, and I'm sure you're doing this, train them in PHTLS. And the treatment here is finger thoracostomy. That's what I would do. Because the problem is, I've gotten called by, a PA who's, at the embassy and not at the hospital, and they want permission to do a chest tube. The problem is they've seen a bunch of chest tubes. They may have done it under supervision once. And then if, you say, go ahead and put a chest tube in, they connect it wrong. They don't have it, and then it doesn't function. So that's a problem. It's not so easy if you don't have the experience, but a finger thoracostomy, if everyone's trained to do it, make an incision and pop your finger in or poke in with a Kelly clamp, and then put your finger in, you feel the smooth visceral parietal pleura, and then you repeat that as often as you need to, and then there should be a rush of air coming out. That is hard to screw up. You just, and if you do it in the right place at the mid-axillary line, at the fourth interspace, it's the chest wall's pretty thin there. That's what I would do in this case. And the other thing is, there was a comment that's why not to intubate, because then you'll generate, you'll create a tension pneumothorax. But that's the same if you're using, it's even worse if you're using a non-definitive airway. If you're masking the patient, bagging them, you're going to have the same problem with higher ventilatory pressures. So I don't think that's a reason not to intubate. I think the patient needs to be intubated, intubate safely, and then be prepared to do a finger thoracostomy.
Okay, Dr. Epstein?
I agree. I like the idea of a finger thoracostomy. I'd like to make a comment on the medications. In England, I believe there's a physician on many ambulances. Correct me if I'm wrong. And so they have the ability to use the rocuronium. If a medic there is going to use rocuronium, you should do it after you get the patient intubated in case you have a problem in those doses. But finger thoracostomy is really the answer.
Dr. Epstein, that is only in London and Birmingham. Other places don't have physicians in the ambulance. These are very specialized area where they do that in England. And they have a vast experience in doing that as well.
And that's why they developed that protocol with the use of rocuronium.
Right.
On which you can't really do until you have the patient, in my opinion, the patient intubated in this rural area.
Okay, Dr. Frisbee, any dissenting opinions?
What? Oh man. Yeah. Finger thoracostomy is a very, very elegant way of doing things. If you've got personnel that, might be a little bit tentative to putting a trocar and then following it up with a chest tube, especially if they've never done it before or have only done it in a limited ways, use the finger thoracostomy. That'll help you.
Okay. Okay, Dr. Quesada, would you mind continuing?
Thank you. So
sorry. Can I make some comments from Gustavo Fraga from Campinas?
Of course.
Very difficult this situation because depends of the law in each country. Like in Brazil, the intubation and chest tube, only the physicians can do this, not the paramedic, not the nurse. But you have a critical patient, you need 2 hours to transfer this patient. And I think there was a rural physician. This is why it's very, very important to teach this concept of the ATLS to all physicians and the course for nurses to everybody. You have so many physicians, they need to have practice. To intubate, I think it's much, much more dangerous, the intubation, and was successful. And now I think it's time to put a a chest tube on the right, a finger thoracostomy. But if you don't do this, the patient probably will not survive until you arrive in the hospital. So you have telemedicine. The physician can send the command for the nurse who is there to put a finger thoracostomy to save the patient. Thank you.
Thank you, Dr. Fraga. So yeah, no, we are trying to change this in my country. We start in thinking with the idea of emergency critical care. So we start with the critical decision like that in outside of the ICU. No? So we have this article when illustrate the survival critical chain. So we decide based in that idea of emergency critical care.
Doc Ariel, este mensaje le va a llegar cuando lleguemos a la Y de la entrada TAIS, le cuento. El joven, cuando lo intubé, inmediatamente después se tensionó. Tuve que hacer una toracostomía digital del pulmón derecho. Se tensionó de nuevo del pulmón izquierdo y le puse otro tubo a él. Y ahora ya está estable por fin. Todo eso en el centro de salud y como ya no tenía oxígeno, tenía que ponerlo rápido en la ambulancia. Aquí ya está estable ya.
In the left, you can watch the video when the paramedic did the finger thoracostomy, and in the right, you can watch the video they sent me after that when reconnect with the signal of connection. I have to wait about 2 hours to have an answer because we lose the connection, and I don't know in this moment what happened. No? But he decided to continue with the finger thoracostomy. But we have a new problem when he ends the finger thoracostomy and decide to change the hemorrhage valve and put in the orotracheal tube, used like a chest tube. You can watch in this, but and put the hemorrhage valve. No, we think that could be a good option to the prolonged transport, but the patient continue with a hemodynamic instability. So reevaluate and find no sounds in the left side. So we have bilateral pneumothorax. So he decided to do a second finger thoracostomy in the left side. So what happened here? No, we was before this case, we was learning and finding a lot of evidence, and he have a paper who illustrates the ability of the pre-hospital professionals to find the correct space to put the needle thoracostomy. So you can watch is not the correct. No, in the third part of the paramedics can know about the correct. No, some the 2 tiers of the paramedics in the study don't know where is the actual the exactly space, and nobody of the paramedics on the study finds the correct space. You can watch in the start. All the paramedics choose another option. No? Is about 2 or 3 centimeters the correct space. So in this part, another paper we have, or we know about the surgical techniques resulting 60% of improvement in vital signs. So we decide the needle thoracostomy for that. No? He have another paper. In this moment I have to remember that because needle thoracostomy in this American Journal of Emergency Medicine was reported that 8% of failure rate, no? But the tube or simple thoracostomy probably have the same percentage, but of success rate. So We have now ultrasound in this ambulance, so now they aboard the ambulance can reevaluate all the time and take some more exactly signs in the ultrasound to the side. Now we have a recommendation from PHTLS to avoid these probably recommendations who I learned and I teaching to probably in case of do the needle thoracostomy. So now with the ultrasound we can avoid that and probably decide to do invasive procedures like needle thoracostomy with more secure in the diagnostic. No, so we adapt a lot of the ambulance Victoria service procedures, and we are training in that. So is the correct? I don't know what doctor said about the identify what the correct space, and then can do that. No. Then we can arrive to the Macas General Hospital, so that's a basic hospital. He just have a general surgeon, emergency physician, and just the basic physician. So then continue with the evaluation and do the CT scan. You can watch the So that's the CT scan when the patient arrives, and you can imagine the no good comments we received from the physicians on the health center. So I don't know, what do you think? You think was the correct option?
Okay, Dr. Fraga, why are we going to start with you now?
So there was the bilateral chest tube, correct? Before transfer, the bilateral chest tube, you put it? Dr. Yao.
Yeah, it's bilateral chest tube. It's not actually a chest tube, it's an orotracheal tube, so we have to improvise.
Yeah, so I think you have a pneumothorax bilateral. I need to change this tube for an appropriate tube, a chest tube. I think it's better for the patients. And how was the patient hemodynamically? Stable at this time?
After that, stable.
Stable. Good, better. So I think you need to change this tube for a chest tube on the right, on the left. Thank you.
Thank you.
Okay, Dr. Epstein?
First of all, those pneumothoraces are not that bad considering what's been going on for a 2-hour ride. And the chest tubes or the orotracheal tubes, the endotracheal tubes can be readjusted to new chest tubes. But that is not bad for those medics transporting this patient. And I'm sorry that you received comments that were not fantastic about the placement of the chest tubes. You can go ahead and fix it. You have the CT, you know what to do. As far as Dr. Kasim mentioned, Dr. Trunke mentioned where to put these chest tubes and where to put a needle. ATLS was teaching to put the needle in the midclavicular line, second intercostal space, which that paper showed almost never worked. And from my personal experience of hundreds of these, they weren't in.
Yep.
So that paper is a very valid paper.
Amen. Dr. Kasim?
Well, your director of trauma who criticized, he needs to go back and learn how to be a little more praiseworthy to what you people have done in the jungle. I mean, imagine doing all this in the jungle. I would be nervous as hell. And I think you did a fantastic job. I thought I saw residual pneumothorax on the CT scan on the left, a significant amount. I may be mistaken. Any case, I think you did very well in austere situation in trying to keep the patient stable as much as you can with the equipment you had. And I don't think I'm going to fault you, fault your team, or anything like that. In fact, I would be showering you with praises for what you've done to keep this patient alive for a 2-hour ride all the way from jungle to humanity. I think, of course, I will change the ET tube to a chest tube, and that's easy done if you're in a hospital situation. I think there are several things that we learned from this case. You know, when you have one pneumothorax, don't forget to look on the other side. Quite often you will have two. One doesn't go. One is the single number. Two makes sense. Even in a bullet wound, if you have one bullet, look for another bullet. Or if you have one injury in the hole in the bowel, there must be another one somewhere hiding. And those are the lessons that I learned from this case. But I think you did a fabulous job as far as I'm concerned, and to keep the patient alive in an austere situation and returning him to a hospital where he can be easily cared for by attending physician. Thank you.
Thank you.
Dr. Collet, you were reluctant to intubate this patient, and now that you saw what happened, I admit I see a lot of merit in your approach. So anything that would reinforce the decision of not intubating this patient, considering that you are in a very austere environment and you don't have too many resources, based on what we know so far.
Oh, Dr. Guzman, I have to congratulate the case for the treatment that can do with little equipment or resources in the area that they have, and they could take these patients alive to the hospital. I disagree with the comment of the patients who received this case because the patients stay alive. I think something may be associated with the ventilation, this pneumothorax, this bilateral pneumothorax, and sometimes it's very difficult in this situation when where there is no much resource, you can do the best for the patient. I think they do the best. As a driver, I think that the chest tube must be changed. Sometimes maybe change usually with another chest tube, or they will go to a thoracoscopy and put a chest tube with the direct vision and see there is no injuries, and there's sometimes pneumothorax with these associations, hemothorax can clear the pleural cavity. I believe that's possible. I think these patients sometimes maybe avoid intubation using no invasive ventilation and transfer this patient. You can do what you do in the jungle, in the pre-hospital, can do during the transference of the patient. The patients in need in these situations go with some doctor. If they don't go to a doctor, there is a problem. Only per hospital is very difficult, maybe unsafe for this transfer. But if you don't do these resorts, there is no possible the doctor. You can do what you do in the site when you in the jungle, and then put in the ambulance and transfer as soon as possible. But I think it's very important to train the doctors who are near to make some procedures and try to refresh the procedures to avoid problems. So, but you can see that your equipe is very well done and do the best for this patient. Congratulations.
Thank you, doctor.
Okay, Dr. Frisbee.
Well, you know, I appreciate all the comments. I don't know why you caught some grief. You know, we always know we can do the difficult. Impossible takes just a little bit longer, but we can do it too, just depending on what we've got at hand. You use the tools that you have for the betterment of the patient. And in this case, you did a great job. Congratulations.
Thank you.
Okay. Dr. Umtrek, some final comments from you.
Yeah. Who was critical? Was it the chief of the service? Is that who gave the bad comments?
No, the general surgeon who was in the hospital.
And so he's not. It looks like he's too many years beyond retirement. He should have. But you know, that person needs to be taken to the woodshed by the hospital and you know, put a sock in it. I mean, you know, this patient, if not for a properly trained and coordinated team, would have died. It's not like somebody who would have arrived alive no matter what you did or despite your efforts. He survived, and we all agree, because of your efforts, because you had good central command and good people in the field. And I think that's because you're doing everything right. You're grooming your people under direct supervision. Then you send the best out to the remote areas, and you make sure they know what to do. And to say, well, you're not a doctor, you can't put your finger, you can't do a pleural rectal exam, you know, put your finger and save the patient's life. You know, and they wouldn't do that because that's scatterbrain. But the general surgeon, it's people like that give us a bad name. That's why people think we're putzes, you know, because and you're not a surgeon, I take it. You're an emergency physician, but you did a great job. It's admirable, and it's a great case because it's different from the usual one. And we all learned a lot. It's airway, breathing, circulation. Keep the patient alive. And most patients die because of this stuff, not because you didn't, you know, do a portacable shunt or you didn't do it heroics in the operating, because you just did common sense things and you did it well. Very impressive.
Thank you.
Yeah, I would like to add to that even if the paramedic is not allowed to do certain things, in a case like this, you have to try. I always say you cannot kill a patient twice. If the patient is dying on its own, you cannot kill it more. So maybe whatever you do will work, which is what happened in this case. And it's fantastic. With his ET tube, you saved this guy's life.
Thank you. So just I have the X-ray when he arrives to Cuenca, to Macas, the health system transferred to Cuenca to the trauma center, and when he arrives, he changed the tubes to chest tubes, and then with appropriate management for the thoracic surgeon specialist, who was my friend, we can continue with the evolution. And in the head, he don't have a really big hemorrhage, have an diffuse axonal injury. So he have to stay in the hospital for that. Don't need really a lot of surgeries of neurosurgeon, and in the chest have contusions, and just wait for with the chest tubes in the ICU, and then he can go home. Now we have a video who was published in the hospital site, so I can play for you.
Ricardo, un paciente de 36 años, oriundo del cantón Taisha, provincia de Morona, Santiago, regresa a su tierra natal con el alta médica luego de permanecer hospitalizado durante 3 meses debido a la gravedad de su salud ocasionada por un accidente de tránsito. Estaba aproximadamente 1 mes en UCI, fue sometido a varias cirugías a través de un equipo multidisciplinario de traumatología, cirugía general, microcirugía y cirugía plástica.
Agradezco a todo el personal de este hospital porque mi hijo se recuperó con su salud y regreso con la felicidad y con vida de mi hijo.
Yep. Good.
So I have some conclusion. Probably the emergency critical care must start in the ambulance, or at least out of the ICU, out of the hospital.
Before you do this, Dr. Quesada, I have a question. Do you show this video to the general surgeon?
I'm not sure. Probably I have to send
Show
it.
it.
If
Show
you
it to him.
didn't, you should.
Yeah. Show it to
Okay,
him.
thank you for the advice. Yeah, we have to after that we training and study a lot. Probably we are started in our country with the medical direction. It's not we don't have a law who establish the medical direction necessary. So we are working in visualize that for the country to the improve the system with the medical director. So because we have to clinical decision make it must adapt to the context and probably in sometimes not just follow the protocols like in this case.
That's
So
right.
thank you.
Right.
This is my team.
They did well. Good.
Thank you very much.
Thank you. Thank you for the invitation.
Congratulations, outstanding case. Congratulations. I'm here with 5 students the last year of the medical school, and they learned a lot. And they need all students, physicians and nurses. They need to know about the emergency, how to treat a patient in a critical situation like this one. And just remember the importance of telemedicine. This meeting by telemedicine started 16 years ago. Nowadays, with internet, you can guide a nurse or a young physician how to treat a patient if you have the sign in internet. It's very, very important. Congratulations. Excellent case.
Thank you.
Thank you, everybody. Great case. I put the CME information in the chat for everyone who's interested. Dr. Quesada, thank you very much for presenting today. Have a great day, everyone, and the rest of your week.
Thank you. Nice to meet you.
Thank you.
See ya.
Thank you, Dr. Hoffman, also for moderating. I really appreciate it.
Very crappy job, but
You did fantastic. Thank you very much.
Fraga had a nice hat, didn't he?